Check. 1, 2. Microphone check. Check, 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 check. Okay, everybody. Hopefully you guys can hear me okay. I have a new microphone set up, so hopefully there are no audio issues. Let's see something real quick. Where is my... Okay, so hopefully there's good audio on here. I have a new microphone, new setup, etc. So this lecture is still important. It's like eating your vegetables. So still important. Okay, so this is a supplemental lecture. Like I said, still important. Still gonna get test questions from here. Still good stuff. So let's get into it. First, I like this table a lot because it compares the effectiveness of contraceptive methods. Most effective up here at the top, and down here we have the least effective. So just to note here that the percentage indicates the number out of every 100 women who experience unintended pregnancies within the first year of typical use of. So it's nice that, so this is nice visual representation, and you can read through these. But so the most effective are going to be either reversible or permanent, which permanent is sterilization. And then the reversible is going to be the implant we talked about, the Nexplanon or an IUD. And then we go down here. So it's good to look at this. And also note that male condoms are important to help reduce the risk of sexually transmitted infections. So that's going to be your best bet if you're trying to prevent STIs. And then LAM, lactational amenorrhea method, is highly effective. And that is when a woman is breastfeeding. They can't get pregnant. And then note 2, emergency contraception. So we're going to talk a little bit more in detail about this in some slides coming up, but it's either, so if they copper IUD, not the other types, the LNG IUDs, but specifically the copper IUD can be effective. And then there's some pills that we're going to talk about some more slides in more detail. So read through these, be familiar. You don't have to memorize the percentages, but I do want you guys to know in general where these fall on the spectrum. So are they falling more in the more effective or less effective? And then the condoms are the best for STIs prevention. And then we have some tips over here how to make your methods most effective. So you can read through those, but I won't necessarily pull test questions from here. But it's important, good stuff. It'll help you personally, and then also for your patients, help them prevent unintended pregnancies. So I just want to note here too, we have the fertility awareness based method. This is also called the rhythm method. So this was popular with my grandparents' generation, Catholics. They don't use contraceptives or whatever, but so they use the rhythm method. And my grandpa always joked it's called Catholic roulette. So they ended up with 7 kids in 10 years. So it didn't work that well. But you may hear that fertility awareness based methods. Lay public will probably refer to it as the rhythm method or the calendar method, or they're counting the day. I don't know. They'll mention it differently. And that's it for that. This is interesting too, in that it shows the pregnancy rate percentage during the first year of use of contraceptives. It has typical use versus correct use. So typical use is what most of your patients are going to be doing, how they are using it, and correct use is kind of in a lab setting, a sterile lab setting. So it's not like what most people do in practice. This is more what your patients are going to be seeing with these. So you'll notice that again, most effective to least effective. But you'll notice that some of the percentages don't vary much. So these IUDs, female sterilization, vasectomies, the Nexplanon implant, you'll notice the typical matches the correct. But then when you go down the list, you'll notice that there starts to be more discrepancy. So even things like with the patch or the pill, contraceptive patch, should be less than 1, so it should be similar to an IUD, for example. But then out in practice, with women using these or taking these, that they are not as effective as with correct use. You notice that too with the male condom, 2% versus 18%. So, and I like here they went ahead and put no method. I thought that was kind of funny. So this is the least effective way to prevent an unintended pregnancy, is to not do anything to try to prevent it. But even then, you get 85%. So I just thought that was interesting. But again, for testing purposes, don't necessarily memorize these percentages. Just take home point is that, so you'll see the correct use sometimes listed from drug manufacturers on certain sources. They'll have these as, this is how much, this is how effective they are, like with the pills especially. They'll say, look, it's, less than 1%. But definitely, I want you guys to remember and to know that you have to be concerned with typical use too. So what your patients will probably be doing and kind of their percentage rates because of that. So changing gears a little bit here. We haven't formally discussed these, but I've mentioned them before, but here are the drug ratings in pregnancy from the FDA. A being the best, or the safest rather, and X being the most dangerous. So X is contraindicated in pregnancy, and it's an absolute contraindication because there's been demonstrated fetal abnormalities, harm to the fetus, harm to the mother, etc. And so it is contraindicated in women who are or may become pregnant, which is important to note. And then it gets the risk gets less as you go up. So A being the best, or so rather the safest, controlled human studies show no risk. And then we have B's no evidence of risk in studies, and then C, where unfortunately a lot of drugs fall, risk cannot be ruled out. So this is one where you kind of use your best clinical judgment, risk-benefit analysis, see kind of how much distress the mother's in, and then whether or not the medication will have an effect on the mother or the fetus in a negative way. And then D is a little more strict. It's positive evidence of risk. So this is, for example, I like this example, if a drug is needed in a life-threatening situation or for a serious disease in which safer drugs cannot be used or are ineffective. So that you may still see some of these being used. But I mentioned to you guys before that these are actually, they're supposed to be phased out. I don't know how it is out in practice or how it's going to be out in practice for you guys, but definitely so far, you still hear practitioners, pharmacists, clinicians, etc. They still refer to these drug categories. But in 2014, the FDA has proposed to phase these out. So I don't know what's going to happen with these. I still want you guys to be familiar with them because even if they are officially phased out, just because there's a lot of people still refer to them based on these pregnancy categories. So anyways, but just know that you will see new labeling out there and new categorization. So if you go to this website here, Pregnancy and Lactation, it takes you to the FDA website so you can read it all more in detail. Don't stress about that. I do want you guys to be familiar with the pregnancy categories and kind of what's the best and what's the worst, and then what does each category mean. And then here's an example of the proposed changes. So currently we have pregnancy, LND, nursing mothers, and we're going to keep pregnancy, put LND into pregnancy. Nursing mothers is going to go under a new lactation category. And the brand new one, which I think is good, I think this is an improvement, is that there's going to have for female and males of reproductive age. So the implications for fertility for both females and males. So I think this is a good change. I'm thinking that these are still going to stick around. And so I'm kind of thinking probably there'll be a hybrid of the two. I don't know, but we'll see. We'll see what happens. And then here's the official language from it. This PLLR is the pregnancy lactation labeling rule. So you may hear the PLLR plur. I don't know if they're going to say that or not, or the final rule, which I feel like is kind of dramatic, and I'd be surprised if people refer to it as the final rule, because that sounds scary to would-be mothers, right? But anyways, this is just saying that it's going to require changes to content and format, and so you will probably be seeing things, and they're going to be removing these categories, and then there's supposed to be updated information. So I've seen some of it in some of the, like for example, on Micromedics, it's one of the drug resources I use. I have noticed that they've changed their language on some of their drugs. It's interesting. So some of the drugs that they still have the older language, but then some. So I guess it's slowly being updated. So now we're going to go into over-the-counter medications during pregnancy. So this is the basics, quote unquote. So this is going to be, so definitely, so anyone who's pregnant or any family members, always check with OB-GYN for their specific recommendations, because every patient's different. They all have comorbid conditions. So this is a general overview. Again, kind of a basic presentation for your average patient, but make sure you, always kind of, if it's you personally or a family member, loved one or whatever, just check with the OB-GYN. And you sometimes have to make, like with a lot of things in medicine, it's going to be custom tailored to that specific patient. So having said all that, typically you start with, for pain, you're going to want to start with acetaminophen, which is generic Tylenol. So that's generally considered to be safe. It's the pain medication of choice over the counter for pregnant women. It's partly because of the NSAIDs or other over-the-counter medication may be associated with infertility, is part of it. So NSAIDs in women. So that's something to counsel your patients on if they do chronically take NSAIDs and they are trying to become pregnant, they are having difficulties become pregnant, that it may be related to the NSAIDs. The NSAIDs also have other effects, especially in the last 3 months of pregnancy. So they're non-teratogenic, so they don't cause birth defects. However, they can cause prenatal constriction of the ductus arteriosus, persistent pulmonary hypertension, renal dysfunction or failure, and intracranial hemorrhage. So they're not as safe to use, especially later on in the last 3 months of pregnancy. So I included these charts in here. I think they'll help you guys, but they're going to have, so pay attention to the title up here. So OTC pain medications, pregnancy. So you notice here, Tylenol, acetaminophen is the pain reliever of choice. And you'll notice here they have the pregnancy category for first, second, and third trimester, which is nice because that plays a bigger role. So these three are NSAIDs, which we haven't talked about the NSAIDs yet, but these three are NSAIDs. So you'll notice in that last trimester, the third trimester, they are all category D, so they're considered less safe. So use with caution and then avoid in third trimester. And then the aspirin is not recommended, except for specific indications. So read the asterisks there. But because you'll notice it is category D for for first, second, and third trimester. And it's also because it is aspirin is possibly teratogenic. So here with decongestants, expectorants, and then antihistamines, it's recommended to go with the chlorphenamine is the drug of choice, antihistamine of choice. Chlortrimeton is one brand name. And then we have pseudoephedrine here, which is this generic Sudafed. This one's interesting because it says it's the oral decongestant of choice. However, decongestants are not the preferred agent for the treatment of rhinitis during pregnancy, just in general. So it's, I don't know if it's considered the decongestant of choice. I kind of disagree with that a little bit. And then it's supposed to be avoided the first trimester. So they didn't put that here too. So add that here for pseudoephedrine, that it should not be used the first trimester. And then in general, decongestants are not the preferred agents for the treatment of rhinitis during pregnancy. So that's something to think about there. Then we have guaifenesin, expectorant, may be useful in pregnancy. Dextromethorphan may be safety in pregnancy. Oh, and by the way, pseudoephedrine, that also goes for phenylephrine too over the counter. So that's what I said for pseudoephedrine is exact same recommendations for phenylephrine, which is also over the counter. So dextromethorphan appears to be safe in pregnancy. Diphenhydramine, it has a better categorization as B, but it has possible oxytocin-like effects at higher dosages. So be more conservative with the dosaging and that. And then clemistine is another antihistamine, the Tavist, unknown. And then here we have the antidiarrheal medications. You'll notice the safest one is the kalinpectin, which is kaopectate over the counter. So it's the antidiarrheal of choice because it's not absorbed. The bismuth subsalicylate is not recommended because of the salicylate absorption. And loperamide, probably safe. It can increase fetal cardiac malformations with the first trimester use, so I would be more conservative with using it first trimester. And then the atropine diphenoxylate is not recommended. That's Lamodal. This was prescription strength. Actually, this one's not over the counter. This is prescription. I don't know why this is on this chart. So this is a prescription medication. Antacids. So you'll notice here these aluminum hydroxy. The Maalox and Tums are generally regarded as safe. The simethicone, also generally regarded as safe, which is Mylanta. And we have some of the H2 blockers. You'll notice cimetidine and ranitidine are preferred. So, and as antihistamines, H2 blockers, and then the Axid and Pepsid are not recommended, or they're probably safe. This one would be more concerned with. Then we have some of the topical antifungal medications, and you'll notice here they all are category C. So they have a couple of them. The Femstat, Monostat are probably safe, and you'll notice the Lotrimin, the clotrimazole is safe in second and third trimesters, and probably safe in the first trimester. So, and then just in general, the vaginal topical azole products, the 7-day therapies, are preferred treatment of vaginal antifungal infections in pregnant women. So now changing gears a little bit here, we're going to go to EC, emergency contraception. So textbook definition is intended for an occasional or backup use and not as a primary contraceptive method. So if you're encountering your patients that are using this frequently, you need to think about prescribing them some other form of contraception. And it is for women who have had recent unprotected intercourse or had a failure of another contraceptive method, for example, broken condom, could be candidates for EC. And it's important for patient education to educate your patients about the availability, their options of EC, and then definitely offer contraceptive counseling. And if they were using a method that failed, talk to them about that and some strategies to improve that. And then, or if they're not on any kind of regular contraception, talk to them about it and maybe prescribe them something. So I mentioned already that you can use the IUD, the copper IUD, but some women don't like that, or they may not be available depending on where you're practicing. So if a woman does not want it or you don't have access to it, the copper IUD, so right up here, copper, you can go with these two medications. So ulipristal, its brand name is Ella. Isn't that cute? No. And then levonorgestrel has a lot of brand names, but one that a lot of people are familiar with is Plan B. They have so the levonorgestrel has a ton of brand names. Aftera, E-Contra, Fallback Solo, My Way, Next Choice, One Dose, all kinds. Plan B, One Step, Take Action, React, all these different brands. So you'll see that a whole bunch, and they're over the counter. And at most pharmacies. You can see them at whatever Walgreens or whatever. They may be locked up, they may be in a case, but they are over the counter. You don't need a prescription to take them. Ulipristal, the Ella, is relatively speaking is preferred or is better than the levonorgestrel because it's more effective anytime within 120 hours of unprotected intercourse. And it's available all over the world. In the U.S., it's the prescription only, and it's by the prescription name Ella. And this is just FYI, don't stress about memorizing this for the exam. But this is how you dose Ella. It's going to be 30 milligrams ASAP within 120 hours, aka 5 days of unprotected intercourse or contraceptive failure. Versus the levonorgestrel, which is Plan B, one step. I put one of the brand names. It can be used anytime during the menstrual cycle. They have a 2-dose regimen and a 1-dose regimen. The 1-dose ones are a lot more popular, so the Plan B one-step is a lot more popular, which patients usually prefer those. But you may see the 2-step, but it's just that these have to be done within 72 hours, so you have a shorter window. And they should be as soon as possible. It can be moderately effective within 5 days, but less effective than the Ella. So I don't know, it just kind of depends on where you're practicing. It may be better to give this than nothing if you don't have access to the Ella. So that's something to think about. So now we are going to talk about HPV, human papillomavirus, HPV vaccine. So the available vaccines they have these three, or they had these three. So I'm going to use past tense here. They had these three up until the end of 2016. So as of 2017, and I'm going to provide links to this for the CDC updates, etc. So as of 2017, it's January, this is the only one that's going to be available. So this 9-valent, Gardasil 9-valent is going to be the only one that's going to be available for administration, etc. So by the time you guys are out on rotations, next year, this is, unless the CDC changes again its recommendations, but this is what you'll see on there. So you may still hear about the quadrivalent and the bivalent, because as of 2016 they were being manufactured, so there could still be some around, still out there. But as of 2017, the Gardasil 9, the 9-valent, which actually covers the most types, HPV types. So you'll notice it has the 6, 11, 16, and 18 that Gardasil has. In addition to, it has 31, 33, 45, 52, and 58. So it's a lot more coverage than the bivalent or the quadrivalent vaccines. So for the immunization schedule, in the U.S. they recommend, okay, so this is, again, has been changed a little bit. So before the end of 2016, they recommended the 3 vaccines given over a minimum of 24 weeks. So don't worry about memorizing this, excuse me, for exam purposes, because as of I think it was October 2016, this has become out of date. Same thing with this too. This is a little bit out of date. I mean, read through it. This is what was done, and you may still see this out in practice depending if the practitioners are keeping up with the guidelines or not. So read through these so you can kind of know what shouldn't be done. But practitioners may still be doing this. And then if some of these, if the Cervarix is still out there, or the other Gardasil, the plain Gardasil is still out there, maybe they'll still follow these immunization schedules. But like I said, as of October 2016, these are out of date. This stuff's not out of date, but so the HPV can be given at the same time as other age-appropriate vaccines, as long as it's at a different anatomic site. So when you administer it at the same time with some of these other things like tetanus, etc., diphtheria, it does not appear to have adverse effects. So that's good. It's safe to use in combination. However, if you are outside of the U.S., you should consult local guidelines, the recommended immunization schedule in their country. So this comes up, unfortunately, a lot. Missed doses or alternative schedules. So the ACIP, the Advisory Committee on Immunization Practices, recommends that if a vaccination series is interrupted, it can be resumed without restarting the series. So don't worry about so there's going to be specific guidelines on how they should be administered, but if a patient fails to come back on time, etc., you can just restart it. You can just kind of pick up where you left off. You don't have to go all the way back and restart the series. The HPV is most effective among individuals who have not been infected with HPV, so prior to their infection. So that means before their sexual debut, and this is for both male and female. And so you want to try to get the patient young, and then while they still are a virgin or they haven't had their sexual debut, so to speak. Just kind of a funny way to put it, but this slide is just FYI, the post-vaccination serology. Just initially when they first came out, they were thinking that they need to do this, but it's basically that you don't have to measure post-vaccination antibody titers, so don't worry about that with these. So the duration of protection, they're still trying to see, further data still needs to be collected. They still kind of need to see what's going to be true in a couple decades, but so far they've shown excellent duration of protection. So it just, but they still kind of need to wait and see. But so all the vaccines that are available are virus-like particles, VLPs, and they mimic the viral capsid. So they do not contain genetic material, and they have very well-established safety records. Even though they don't contain the live virus, they are still not recommended in pregnancy, and this is basically because they have a limited amount of data on safety. Lactating females can receive the injection since it doesn't affect the safety of infant breastfeeding. But note on here that, going back to this slide, that it's supposed to be before their sexual debut. So if they're pregnant, they've already had sex. So I'm not saying to never give it to a breastfeeding woman, but just keep that in mind. And then so pre and post license monitoring or post-market surveys have showed that they are deemed to be generally safe. So this is kind of one of the controversies that was around when they first came out. They were afraid, or parents were afraid, that it was going to have a behavioral impact. So they've looked at that, done some research on it. So there were parents that were concerned about that their children be sexually disinhibited after they got the vaccine. So they thought that they would, they're kind of invincible and they didn't have to worry about STIs and STDs and stuff. However, the good news is that the studies that have been done have not supported an increase in risky sexual behavior following vaccination. And then this is another study that basically showed the same thing, that the HPV vaccination was not associated with an increased rate of sexual activity related outcomes. So that's something that your patients may be concerned about, and this could be part of your patient education. So I'd recommend, I'm always talking about UpToDate, but UpToDate has some patient information, kind of handouts and pamphlets and stuff, which are really good. So the Advisory Committee on Immunization Practices, the US ACIP, now recommends only the 9-valent HPV vaccine. So again, as of October 2016, for females aged 11 to 12 to help prevent cervical, vaginal, and vulvar cancer. And it also recommends the 9-valent to help prevent anal cancer and genital warts. So the 9-valent, like I already mentioned, has the widest coverage, has the most coverage, and as of 2017, it's the only one that's available. But you will get questions from patients' parents that they were vaccinated with the older ones or with some of the other things, and they, do they need to be revaccinated? So again, according to the guidelines, etc., CDC, the ACIP, they do not warrant, or they feel like it's not warranted if they've completed their series to then go ahead and restart with the 9-valent. They've also, however, shown that there isn't necessarily a harm in doing that, in having. So if a person desires to be protected against the 5 additional types that are prevented by the 9-valent, and they've already finished the other one, so the ACIP doesn't have a formal recommendation to do so. However, there hasn't been any evidence that's shown that there are serious safety concerns in a person who is already vaccinated with with a version other than the 9-valent, and then they go ahead and get the 9-valent afterwards. But so just know that. So the official kind of recommendation is that you don't have to do it and that it's not necessary. But if the patient really wants to, it wouldn't cause the patient harm. Or rather, of the available data, they show no serious safety concerns, is the language that they use. It is interesting, though, so if the patient has started with the quadrivalent or the bivalent, they can complete their series with the 9-valent. So that's something that so they can finish with a different product, a different vaccine, if they're interested in that additional coverage. So, and the good news is it's all being kind of streamlined, and all that's available now is the 9-valent. So it'll just be this transition period where people will be concerned and wanting more coverage, etc. So these can be given to males and females as young as 9 years old. They do recommend catch-up vaccination for females 13 to 26 who have not been previously vaccinated or have not completed their vaccine series. So the ACIP, again, recommends the routine use of the 9-valent as of October 2016 for males aged 11 to 12, and it can also be as young as 9 years old in males. And then it's also recommended for males 13 to 21 who have not been vaccinated previously or have not completed the 3-dose series. And then specifically for males who have sex with males, aka MSM, and for males who are immunocompromised. So this is certain cancers, or rather if they're on chemotherapies, which we've talked about, or they have HIV. The ACIP recommends vaccination through age 26 for those previously not vaccinated. And then repeat vaccination with the 9-valent is likely not warranted for individuals who have completed a series with a different HPV vaccine, which we already talked about. So there have been some controversies and some opponents to the HPV immunization, specifically that they didn't think that males should be vaccinated. So these were their arguments. And then there were proponents of it. So I don't know if you guys remember this in the news, or this was a pretty popular topic a few years back, but should males get it or not? So you guys can read through that. But just so you know, the guidelines from ACIP and the CDC recommend that that there is routine vaccination for men and women, females and males. So that's where the CDC stands in the ACIP. So you may hear some of the controversy, and then I usually just, the CDC is pretty well known, so I usually refer people to the CDC if they are concerned or have questions or whatever. And speaking of, so this is up to date updated. Sorry. I love up to date so much. I'm just like jamming it in sentences where I don't need to jam it in. So up to date information. I did it again. Okay, updated. The CDC and the ADIC updated their recommendations, the guidelines in October 2016. And you guys can go click on either of these. And I'm actually going to take you guys on a little journey. Let's see if these work. Okay, so here are the two PDFs that I gave you guys links to. This one I really like. It's a pretty quick, leave me alone, Windows. It's a pretty quick PDF. It's 4 pages, but one of those pages is all references, pretty much. So this is really good because it gives a quick little summary of basically the 9-valent is the one that is going to be after the end of 2016. Only the 9-valent will be distributed in the United States. And by the way, that's how they abbreviate. They put 9V HPV, so you may see that NV, but it's Gardasil 9 is the brand name made by Merck. Thank you, Merck. So that's the 9-valent. It's the only one that's going to be distributed in the U.S. So there'll probably be some more, people that had bought, extra of the other ones. You may still see those around in clinics, etc. But then also in October 2016, they updated the ACIP, updated the vaccination recommendations regarding dosing schedules, and the CDC concurred, so they now recommend 2 doses of the HPV vaccine in a 0 and a 6 to 12 month schedule if they are starting the vaccination before their 15th birthday, and then a 3-dose HPV vaccine, so 0, and then in 1 to 2 months, and then in 6 months, continue to be recommended in persons starting the vaccine series after their 15th birthday, or if they have certain immunocompromising conditions. So I mentioned cancer, certain cancers, patients like chemotherapy, and patients with HIV. And this is a good summarization, so I would read through this. So here's some information about the vaccines, and the different cancers, etc. And then this is a lot of this. I like this part that are in red because this is going to be a lot of the questions you'll get from patients. So definitely keep this handy for rotations, but double check with that CDC, I guess, in a year and see if it's still relevant or whatever. But so I gave you guys that link, and so check that out. And the other one I gave you was this. So this is the article about the use of 2-dose schedule for the HPV, updated recommendations. And so and I put this in your slides, but I like this table here. I mean, if you have time, read through the whole thing. It's a lot of good stuff. But this table here is good because it gives you the new recommended number of doses. So again, if they're ages 9 to 14, so before their 15th birthday, they get 2 doses. If they're between 15 and 26, they're going to get 3 doses. And this is for males and females, except immunocompromised patients. So note that. But then, so they only have the 2 now, and then it's going to be it's going to be the 9-valent. So this 9-valent HPV that they're going to get. So here's that table blown up for you guys, but so definitely remember that. I definitely put a star by here, for testing purposes, etc. I want you guys to be memorizing and be knowledgeable of the most up-to-date recommendations. So as of October 2016, you guys are up to date. Woohoo! And then hopefully for me, it doesn't change. So I don't have to change my lecture next year. That'd be awesome. No. But so again, if they're 9 to 14, they're going to get the 2. Unless they're immunocompromised. And then if they're older, 15 to 26, they're going to get 3. And it's going to be the 9-valent as of the end of 2016. That's all that's going to be manufactured via Merck. So it's going to be the Gardasil 9 is the brand name on that one. Okay, so now we're going to get into the woods here. It's going to get kind of hairy, but I think I'll be able to kind of reduce things for you guys so that it's pretty clear cut and not super confusing. But we are going to talk about Rhogam is the medication that we're going to talk about eventually, but get a little bit of background. Is that in OBGYN, you sometimes need to prevent rhesus, alloimmunization in pregnancy. So read through this. I'm not going to be pulling heavy test questions from this background stuff. I'm just trying to give you guys a better idea, kind of better background. So rhesus was abbreviated RH. D negative pregnant women who are exposed to fetal D positive red cells are at risk for developing anti-D antibodies. So it's also known as maternal alloimmunization, and it's also known as RH isoimmunization, or you'll hear it called RH incompatibility. And it's a condition that may occur during pregnancy when there's an incompatibility between your blood type, or rather the mother's blood type and the baby's blood type. So during pregnancy, red blood cells from an unborn baby can cross into the mother's bloodstream through the placenta, and if the mother's blood type is different than the baby's blood type, the mother's immune system may treat the baby's blood cells as if they were a foreign substance and attack them and produce antibodies against them that attack that. And those antibodies can cross back through the placenta and attack the baby's red blood cells. So this is called a hemolytic disease of the fetus, and it's a condition in which red blood cells are destroyed faster than the body can replace them in the baby. And then if the baby doesn't have enough red blood cells, then they won't have enough oxygen, etc. So it's problematic for the baby. And then if that's left untreated, it can lead to serious problems. So, for example, it can lead to brain damage, seizures, problems with mental function, etc. Problems with movement, hearing, speech, sometimes even resulting in death. This alloimmunization is not a problem during the first pregnancy because the baby is often, I'm going to sneeze. Wait. Okay, sorry about that. So what was I saying? Oh, so it's typically not a problem during the first pregnancy because the baby is often born before many of the mother's antibodies have developed. However, once the antibodies have formed, then the mother's body does not get rid of them. So any subsequent babies are more likely to have problems if they have the same blood type that the first baby had. So if they're Rh positive fetus neonates and the mothers are at risk of developing the hemolytic disease of the fetus and newborn, and like I said, can cause serious ramifications. So then they developed an anti-D immunoglobulin, which is Rhogam, we're going to talk about here in a little bit. And this has helped a lot with these problems. And this is just kind of FYI stuff. It's just basically there's been a reduction in complications because of Rhogam, or that medication that was developed. And then this is just kind of a background. It's more pathophysiology of what I talked about. But just read through these next two slides, the overview of rhesus D, alloimmunization. It just will give you a little bit more understanding, a little bit more detailed, but for testing purposes, I'm not going to go to that level of detail for pharmacology. But this may help you guys read through these to help kind of explain the story. And it's I summarized it there in the beginning, but just so you have more specific information. So this is the medication I mentioned just a minute ago, Rhogam. It's Rho-D immunoglobulin. So this is the generic name or chemical name, but I'm going to say 99% of people just call it Rhogam. This is the majority of people. This is one of those medications where I'm going to say never, but maybe I rarely, other than in pharmacy school, I haven't heard people call this by its generic name. 99 problems, but Rhogam ain't one. But yeah, so the Rhogam is one of those. So, but for testing purposes, I'll put the generic, but just, out in practice, people will look at you like, what are you talking about? But it's got a couple uses that aren't related to OBGYN, just FYI. It can be used for ITP, the immune thrombocytopenia. It can be used sometimes during transfusions for incompatibilities in blood types, so Rh negative, Rh positive. And then why we are here today is for OB-GYN. So they're used to help prevent the hemolytic disease of the newborn, which I mentioned before. And so it helps with that incompatibility, the Rh positive, Rh negative incompatibility of the mother and the baby. So all products are used for Rh negative mothers who are not already sensitized to the Rh factor. And then an Rh incompatible pregnancy is assumed if the fetus/baby, I don't know why they do that, fetus/baby, just pick, if the fetus/baby, fetus aka baby, aka big baby, aka big fetus baby, is either Rh positive or Rh unknown, or if the father is Rh positive or Rh unknown. So those are those where you can safely assume that you're going to have an Rh incompatible pregnancy. And then the use is not needed, however, if the father or baby is conclusive. Why did they put baby/fetus? So the father or the baby is conclusively Rh negative. So that's important to know. So you don't necessarily have to give it to every patient, but you know, you guys will learn the specifics and kind of the nitty-gritty from your OB-GYN rotation. So there are product-specific indications. So it's going to depend. So these are all brand names. It's Hyper-Ro, Microgram, Rhogam, Roflac, Winro. They'll have Ro in it, I guess, right? These are all different brand names. So depending on your hospital, they'll have it on their formulary, and then they'll have a protocol. So you notice they're a little bit different as far as when you give it, how you give it. Don't worry about memorizing this and stressing out about all the details. I'm just putting this here just so you know, depending on what hospital at, depending on what facility you're at, they may have one of these on formula. They may have a different one. And so just ask for their protocol, and ask the OB-GYN, you know, which one they have, and then how do you give it, and recommendations, etc. So mechanism of action, it is one of these that is not completely characterized, aka not fully elucidated, as they say. But here's the proposed mechanism, that it helps prevent isoimmunization by suppressing the immune response and antibody formation by the Rh negative individuals to the Rh positive red blood cells. And then when it's administered within 72 hours of a full-term delivery, the incidence of Rh isoimmunization decreases from that percentage to 1 to 2%, so dramatically decreases it. And then it further decreases to less than 1% within administration at both 28 weeks gestation and postpartum.